Hello. It's still good morning. So good morning all. Can we have the voice levels a little bit down? I know that you are meeting after a long time, but it's probably a hindrance for the people who want to listen to the talks. So a little bit down the noise levels, please. So my name is Joe. I come from Amala Medical College. At the outset, I thank the Scientific Committee Chairman, Dr. Ashish, and the organizing team for having this event. I sincerely am overwhelmed by seeing the attendance here. Excellent. Why you guys are so important, we'll come to that in a minute. Okay, so this topic, I was going through your syllabus and I saw that this is part of your syllabus. Okay, so the question can be NORA, because that is the term that nowadays is being used for this, whatever we do outside the operating complex. So it's called non-operating room anesthesia or non-operation room anesthesia, anesthesia at remote locations, outpatient anesthesia, or office-based anesthesia. Anything, it's the same. This is where I come from, so I bring warm regards from Amala Medical College. We have quite a green campus, not very far off from here, so welcome you all to come and visit us there sometime. That is what we are going to go to in the next probably 25 minutes. So we'll come to the headings in detail. So a small introduction. My best friend in the OT is without any doubt the DOTT. I know that here generally it's called DOTT, even if it's a BSc nurse, that's how they're called in our theater. So without a doubt, my best friend is a DOTT. In the UK, it used to be the ODP, Operation Department Practitioner. In the US, it's the anesthesiology assistant. So all the same, they're all very, very important people for an anesthetist. Is the scenario different between here and the UK? Yes, it is. I was just telling quite a few of my friends here that in the UK, this is one group that I haven't seen any non-whites. Okay, like there are so many doctors, Indians from all over the world, nurses, lots, but I haven't seen, if I truly say, I've seen only one guy. He had come there, he had actually done his training in the UK. So I haven't seen anybody from here in the UK as an ODP. Why? Because it is a very cherished job there. All the guys there were quite senior, like 45, 50-year-olds, who actually would do the job of an anesthetist. They were that good. Okay, and they had other roles in the hospital. They were probably in charge of the equipments. They were probably in charge of the airway trolley, things like that. They had other roles. They were all quite senior chaps. Okay, so, and it used to be, like as a consultant, I used to know about the trainee from the ODP. So the ODP will tell me, like yesterday when I was on duty, this trainee was there, he had a problem, this and all. So we used to rely on the ODP that much. And coming to that, next one is my hope. Here, I think this is a very new course compared to probably medicine and nursing and things like that and all. This is a very new course, probably 10 years. So in the future, I am expecting again a lot of DOTTs with gray hairs. Okay, so that your input will be much more than how it is now. You will be sort of given other roles and you will be allowed to grow in stature. So that is my hope, and I'm sure it will happen. What are the special problems in NORA? In NORA, outside the theater, if I say, sister, patient is desaturating, I need a mask fast, this is probably the mask that I'll get. In NORA, suppose I want to prone a patient. The things that are available there might make me prone the patient like this. Okay, so I won't have enough things there. The environment that I have to operate or anesthetize on will probably look like this. Okay, there won't be any light, it will be debilitated. So this is the problem with NORA. So emergencies, this is outside the theater emergencies, like it can be the casualty or ED or places like that. So the first thing is urgency. We have limited time to work on. There might not be that many people who know about things, so we might have to multitask. The circumstances can change suddenly. It might not be one patient there, it might be a mass casualty. It might be a few people. So the circumstances change. Like the theater, equipments, you won't get everything there. The equipments might not be standard. Piped gases might not be there. Very worrying, because if the oxygen cylinder finishes, I might not have a reserve. NORA, the site is distant. It's an unfamiliar environment. I don't go there every day. No other expert help. The only help is we both. Okay, or our team. Nobody else is there who knows anything about what's happening. Backups are limited. Somebody will have to come to the theater, will most probably will be on the other end of the hospital. Emergency gadgets and drugs are not readily available. Recovery facilities, have you thought about that? We are giving a full-blown anesthesia. Are we having enough recovery facilities in that place? Scavenging, unheard of. Most of the places won't have any scavenging. So because of that, what is the problem? If you have done a lot of your work there, that day you might feel very sleepy because of the nitrous oxide and the sevoflurane and the isoflurane that goes into you. Space, as I showed that debilitated building, there won't be enough space. The environmental conditions, there won't be any light, the temperature will be very humid, and things like that. The patients, what sort of patients do we get there? Most likely it will be children, adults with developmental delays or learning difficulties, adult patients who are claustrophobic, so they're very anxious, they can have panic attacks. Pain might be the issue, that is why we might need to give them anesthesia. ICU, very sick ICU patients coming for some procedure. Acute trauma, again, needing a procedure in the cath lab. Raised ICP patient, so we are around in case the patient has to be tubed and things like that and all. So where do we tour? What are our tour destinations for NORA? It's the emergency department, ICUs. What do we do there? To resuscitate trauma, cardiac arrest, respiratory failure. It can be the psychiatric suite for ECTs. This again can be asked as a question. Where does NORA apply to? It could be the endoscopy suite. So gastro procedures like ERCP, EUs, pulmo procedures like endobronchial ultrasounds or cryotherapy, radiology suites, why CT, MRI in uncooperative patients or children, or it might be for an interventional radiology procedure, cath lab, labor epidural, oncology suite for brachytherapy or radiation for kids, pain clinic procedures, dental clinics. In the UK, there is or in the Western world, there is something called chair dental. What you do is the anesthetist and the ODP. We go to the dentist. Okay, we go to their OP and anesthetize patients. So how do you do that? You just, with a nasal mask, you gas induce the patient, and in that 2-3 minutes, the surgeon pulls out the tooth or teeth. It's very easy. It's very easy when it's to sound, but those were the days when I used to have the maximum adrenaline gushes. Okay, because there will be 10, 12 kids who are there on the dental chair to have their teeth extracted. Burns unit, infertility clinics for oocyte retrieval or lithotripsy and things like that and all will need some anesthetic service. So one of the most important thing is planning and communication. Just because of the reasons that I said, when we go there, there is not going to be anything. So we better plan properly. Okay, so the team in that outside place is usually the anesthetist and the DOTT. Okay, so we have to plan well in advance for anything that might happen there. So, how many of you are aware of the WHO questionnaire? Can you raise your hands? WHO questionnaire in your theaters? Okay, this is actually a safety checklist. Wherever you anesthetize or wherever you do a surgery, you should have a safety checklist. And WHO has devised one for all over the world, and we are supposed to practice it for every place where we anesthetize. It might not happen in an emergency, but if it's an elective procedure. So our team has to discuss about the details of the case. I'll have to speak to the DOTT about what case it is. What are my plans? What is the plan A of anesthesia? If I am not successful, what is the plan B, plan C, and plan D? Because these are places where problems might happen. When it happens, I have to have other plans. What are the equipments or drugs that I might need? And as per ASA guidelines, you should have an emergency cart and a defibrillator available nearby. Can we please have the sound levels a little bit down? Please. Okay, now, how do you think about what you should get ready? Think the main things first, okay? So one is airway preparedness. What is there in that? Machine check. So when I'm thinking of airway, I'm thinking of delivering oxygen to the patient as well. Okay, so machine should be properly checked. Ambu bag, it's a very important thing. Ambu bag, which has a reservoir bag. Just an ambu bag will give the patient only maybe 21% plus a little bit of flow. Even if you set it at 15 liters flow, it might give the patient only around 35%. So you need a reservoir bag, and the reservoir bag should not have a hole in it. Okay, recently, actually in our hospital, most of the reservoir bags have been fine, but at least 5 reservoir bags, I have actually torn it because there was a hole in it and it was brought to transfer patients. Nobody had checked it. Okay, so it shouldn't have a hole. You should check it and see whether the ambu bag and the reservoir bag is working. Oral and nasal airways, we all know that. Laryngoscope, as per guidelines of ASA, we should have at least one laryngoscope and one battery powered. So when they say battery powered, they are meaning a video laryngoscope. So if you don't have a video laryngoscope, at least 2 working laryngoscopes. When I say laryngoscopes, they should be working. We all know that if the laryngoscope light is not working, it's a waste. It's like a stick in my hand. It's a waste. Endotracheal tubes of different sizes. Bougie, one of the most important gadgets, I'll say, bougie, and a stillet if some people are used to it, which I don't like very much because I think it's very traumatic. There should be a backup oxygen cylinder and a difficult intubation cart if you think that backup cylinder for every case, difficult intubation cart if you think that the patient might have a difficult airway. Suction should be working properly. So how do you check the suction? How do you know whether your suction is working? Ideally speaking, you should hold the tip of the suction and you should hold it at your waist level and it should stay there. None of the suctions in my hospital will stay there. Okay, so they're not ideal, but that is how you check for an ideal suction. Once you put your finger on the top, the only hole, it should actually stick to your finger till you reach your waist level. Emergency. If it's an emergency, you might have to do a rapid sequence induction. So you should know how to do a rapid sequence induction. And what is the burp maneuver? Anybody? Yes. Backward, upward, posterior. Those three are fine. We'll anyway do it. The important bit is the right. Right of whom? Right of the patient or right of you? So usually a right-handed person to give a SLX maneuver should stand on the right side of the patient. So when you're standing on the right side and pressing the neck, the natural tendency is to push it to the other side. And the anesthesiologist is going through the right side to intubate. So you are pushing the trachea to the other side, anesthesiologist can't see it. So that is what happens. So what you should be doing is, you should be pushing it towards the right side of the patient so that the anesthetist can see it when they're doing it. So it'll make things much more easier. Why I've put this up is difficult airway society guidelines. This is the most commonly followed one. There is an ASA one, there is an Indian one, but this is the most commonly followed. Why I have put it up is it is very important. Please, when you go back, it's freely available on their website. Please have a look, because I was telling about a DOTT with gray hairs. Why I want a DOTT like that is, when I am facing a case where I cannot intubate or ventilate, I want the person standing next to me to give me some tips. Okay, because I might be perplexed. Adrenaline has gone up my head. I am not thinking. At that time, I want the DOTT who is experienced enough to tell me like, doctor, do you want this? Okay, and for that, you have to know what I would need next. So basically, initially, after the laryngoscopy, 3 + 1 attempts. 1 attempt is by the expert. So if I am keeping on doing 5 attempts, you should tell me, sir, is it time to do the next thing? Okay, because 3 attempts is what is recommended. If you do more than 3 attempts, I'm not going to succeed, and I'm going to finally do something harmful to the patient. So that is where you can interrupt. You can say that, sir, it's already been 3 attempts. Then you can help me with pressing. Now, there is a difference. SLX maneuver, you are pressing on the cricoid cartilage. Here, if you press on the cricoid cartilage, it is not going to help. Here, you should press you want the larynx to come, so on the trachea. Okay, on the laryngeal part of the trachea, above the cricoid cartilage, the bony thing, your Adam's apple. That is where you want to press so that it is more beneficial. In this case, when it's a difficult intubation. Sometimes you might have to remove your cricoid pressure. That might be the reason why I'm not able to intubate. So you can ask me, sir, should I remove the cricoid pressure? If I am not successful, you can slowly show me the supraglottic airway. That is the LMA. Okay, you can take the ProSeal and tell me, sir, do you want to put the ProSeal in? Patient is desaturating. Once I've put the ProSeal 2-3 times, you can tell me, sir, now should we think about the next step? The next step is again trying and ventilating. Okay. Okay, and then you are probably thinking about a surgical airway. Now, the next question can be, what is the surgical airway called nowadays? It used to be called cricothyroidotomy, things like that. Now don't worry about it. It is front of neck axis, FONA. So once you can't intubate, the current word is front of neck axis. Okay, so you guys, it's not an easy procedure to do. You won't have to do it. But at least, if you know what things I will need, you can get me a scalpel with a size 10 blade, a bougie, and an endotracheal tube 6 size. And you can prompt and tell me, sir, saturation is not there. We have been trying all the things, not worked. Patient is before the patient arrest. Should we consider doing that? Now, vascular access. Out of the theater, I would always probably recommend intravenous access. Inhalational induction out of the theater, might not be the best place because you don't have that many help. If while I am holding the airway, I would need an expert there to put in a line because it might not be an easy IV access. So IV induction probably will be the better option. You should get different size cannulas. Fluids, what fluids you want, you should have a discussion. How do I give it? If it's a very small kid, then you might need a burette set. Okay, how do I decide on a burette set? 20 ml per kilo in anybody who's normal, who doesn't have cardiac failure, will not do anything. 20 ml per kilo. So if I put 500 ml there and the child is only 5 kilos, I can actually give only 100 ml. But in the excitement, probably it's a difficult intubation. In the excitement, I've just put a normal drip. What might happen is 250 ml might just go in and child can have pulmonary edema. So that is my cutoff. Like if it's a 5 kilo child, then if there's a burette set, I can set the limit at 100 ml. So the maximum that will go will be 100 ml. So that's how. If it's a very small kid, you might need a burette set. If it's a larger kid, you probably have seen other infusion devices which has a metal thing, which we use for pediatrics. The difference is the drop size is very small. The drop size is 3 times smaller than the normal drop size. So fluids won't just rush in. Okay, so a bigger child, you can use one of those. In an adult, obviously, you can use the normal one. You can ask the anesthetist whether you will need a central line and an arterial line. Central lines probably, still, emergency, in the emergency department, you might need it. You can ask about that. Now, how do you develop that skill of cannulation? Patients come into a theater already have a cannula. Why don't you go to the ward? All the patients need a cannula at some stage. So you can go to the ward in the morning and tell the staff nurse that I'll do the cannulation. So I would always like my DOTT or ODP to be very good in cannulation. And ODPs in the UK, they were excellent in that, probably better than us. These are the drugs that are recommended by the Royal College of Anesthesia: suxamethonium, atropine, vasopressors. Ephedrine is an alpha and a beta agonist. It will increase the heart rate and it will cause some amount of vasoconstriction. The other 3 are alpha agonists. They won't increase the heart rate. So depending upon how the heart rate is, you can use that. Pediatric emergencies. If it's a pediatric emergency, there is a code, wet flag. Wet, it's a universal code, wet flag. W is weight, electricity. If I have to shock, how many joules do I have to give? If it's a kid, 4 joules per kilo. Endotracheal tube size, fluid bolus, 20 ml per kilo should be ready as a fluid bolus. Lorazepam, if the child is having seizures, then you can give lorazepam. Adrenaline, 10 mics per kilo. So suppose it's a 10 kilo child, 100 mics. 1 ampule is 1 milligram. If you load it in 10 mils, each ml is 100 mics. Okay, so you can give 1 ml of that 10 mils. And glucose if the patient is hypoglycemic. This is the new thing in NORA, non-operating room anesthesia. It's practiced. If you take a flight and go out of India, everywhere NORA will have this. Okay, even in the theater you will see it. Here it's coming up in Amala. This is the one that we have. Lots of companies are there. This is the one that we have. It's called a target controlled infusion. It's usually used for propofol. And remifentanil is the next drug which is not available in India yet. Once remifentanil comes here, probably in the next 1 year, everywhere this will be used. Minimum mandatory monitors. For GA, it is saturation, ECG, NIBP, and ETCO2. For regional anesthesia, no ETCO2. For procedural sedation, ETCO2 if there is loss to verbal communication. If it's just sedation with the patient speaking, mild sedation, then you don't need it. Otherwise, you need it. Audible alarms should always be enabled. Don't put it off. Neuromuscular monitor if you're using relaxants, and a EEG if TIVA is used with a neuromuscular monitor. Mock drill simulation training. Every medical college now is supposed to have a simulation center. We should have such simulations in the simulation center so that we are well versed with it. So when you go out of the theater, don't expect a Mercedes Benz. So don't expect your dragger machine and the workstation and things like that and all. You will most probably have only an ambassador there. An old Boyle's machine will be lying there, but at least ensure that your ambassador is not leaking petrol. And with that, thank you very much.